Hello, this is the full training for the Healthcare Providers Traumatic Brain Injury Toolkit. We like to thank our funders whenever we can, the ACL at the federal level and the Tennessee Department of Health TBI program at the state level. So we are Brainlinks, and it is our mission to enrich the lives of Tennesseans with traumatic brain injury by training and empowering the people serving them. And we provide statewide trainings, evidence-based. We provide materials that you might need for education of your patients, any resources that you might need. We will attempt to get to you or try to hook you up with the people who can best answer you. And we also have toolkits. We have a toolkit for healthcare providers, which is what we're going to talk about today. And I'm going to dig into it and show it to you. I'm going to show you some current issues with the treatment and management of people with TBI from the literature, review some new models. There's some exciting new things happening, and then we'll show you the toolkit. So it's hard to say what a typical case is with a person with a traumatic brain injury because they're all so different. But for us, what we see downstream, the people who are struggling tend to fall into two groups. They're the folks who had a concussion, who maybe had no loss of consciousness, maybe had typical symptoms, a headache, fatigue. A concussion is probably diagnosed, but no treatment is given, and their symptoms persist beyond 3 months, and they don't know what to do. They don't necessarily even link what they're experiencing back to that concussion because they kind of feel like, well, I've been through that already, and there's nothing more that I need, so it must be something else. The other group is kind of these people who had a more substantial injury but never made it through the rehab process. Typically, if folks make it through the rehab process, they have some support that can follow them, or they have a place at least to go back to. The folks that we see that struggle the most, and not that those other folks don't have their issues too, they do, but are the folks who maybe had a more significant injury, a Glasgow Coma scale, in this case of an 8. They had multiple skull and facial fractures, maybe a midline shift, diagnosed and treated at the hospital. In the cases, this is actually like a grouping of several that I kind of had in the top of my head, and they were seen 3 and 4 nights in that range, multiple people with no follow-up referrals. In this case, they were children, no identification at school, and then they are lacking supports initially. Luckily, they got to a program like ours, but there are more that even don't get to anybody. They don't know what to do about it. They don't know what the problem is. So it's kind of the very typical concussion, but then also people with a significant injury that we're looking to try to support you to help. So just a little bit of background information, some numbers. So there were, this is nationally, 2.5 million seen in 2014. That's the latest data from the CDC at this point. And there were 288,000 hospitalizations. What this says to me is that there are a lot of people that are treated and released. Not necessarily a bad thing, but there are a lot of people who are just treated, released back into the community. And then what the final block says to me, the deaths, says that there are a lot of people living with the burden of traumatic brain injury. And those numbers and these numbers are severely underreported because they reflect pretty much just ED visits. And we know that the most people will be seen, 82% are going to be seen in a primary care office as their first visit. The Tennessee data here, I like to show this one because we have had such a great focus on sports concussion injuries in the past several years across the country. So people are really looking for that, but that has really risen to the top of people's minds as that being where we sustain our concussions. And I like to show this because it shows that really just 10% are sports concussion. So although we need to keep the focus on them, we need to also be focused on the rest of the population that sustain a concussion. So like I said, most are going to be seen first by their primary care provider, and that was a very large study. On the medical side, some issues, we are really, really missing the very young. And I think this, more than anybody, we need to be targeting. And there are a lot of issues related to that. One is that under 5 population, there is no validated age-appropriate symptom scale. And the CDC says that that's what we should be using. That is the best practice right now. There isn't one. There's one in the works, but it's not there yet. The symptoms look different for these little guys. We'll talk about that in a second. And I think the biggest problem with the under-identification, or why they're under-identified, is because nobody knows who these people are. They're little people. They haven't gone to school yet, a lot of them. So we don't know what they're like academically. So when they get to school and they struggle, we just kind of think that that's who they are. Or they go on to have behavioral problems, and we just think that that's who they are. We don't look back to the brain trauma and try to get them some specific intervention related to those things. We kind of just try to manage them a little bit. So we really, really need to be looking at the very young. Their symptoms are the same as the older child and adult, but also we need to be looking for other things. Since they can't talk to us in some cases, or they can, but they don't have the right words, they don't know a word like nausea, they can't tell us that that's what they're experiencing. So we have to look for things like appetite changes, behavioral dysregulation, decreased engagement, disrupted sleep, continence issue, increased dependence, stomach ache. So if we can coach the caregiver to look for these things and give her the materials, the parent, the materials that talk about these things, we can help to better identify these kids. I want to point out that the behavioral dysregulation, the decreased engagement, initially after the injury in that early recovery phase, we tend to see decreased engagement. It's over time that then it evolves into behavioral dysregulation, and this can become a real problem at home and at school. But by the time it gets to that point, because it's gone through this decreased engagement phase, it kind of seems new. It kind of seems not related back to that injury anymore, but it is. That's the pattern that we see with these kids. So we need to be looking for these things. And then these are for anyone. There are issues in cognition and communication following a concussion, emotional behavioral issues, and physical issues. Cognitive communication, feeling dazed or in a fog, word finding problems, that's probably related to attention. We see a lot of attentional difficulties following concussion, slowed information processing, irritability, quick to anger, decreased motivation, crying easily, doesn't matter how old you are, headaches, changes in vision, sleep disturbance, fatigue, balance, dizziness, sensitivity to light and sounds, all the very traditional symptoms that you may be aware of. Concussion in older adults, it's different. They are more susceptible to concussions because of the changes that go on in the brain. The vascularization they're much more likely to bleed. Even a fall to the knees or bumping heads with somebody else can create a concussion. It can create a bleed. So they are at a much higher risk of intracranial bleeding, and the signs are often delayed because there's a bigger intracranial space. So it takes longer for that blood to accumulate to the point that it produces symptoms. That same bleed in someone who is younger, who does not have that same intracranial space, we're going to see symptoms much earlier. So we really have to watch them much more for a longer period of time. And they are less likely to be diagnosed, less likely to be treated. And then it's complicated by dementia and other cognitive disorders. So we have to tease out, was this related to some pre-existing thing, or was it related to the concussion, the TBI. And it is worth considering, in my opinion, treating these folks, getting them specific treatment. Let's take somebody who does have age-related changes, but now we put a vestibular issue on them, or we put an ocular motor issue on them. That can be debilitating. So on a case-by-case basis, we really have to take a look at who can benefit from treatment. What is their symptom? Can we teach someone else within their world how to provide some of the treatments? Can they go to the physical therapist or the ophthalmologist and learn the exercises? A lot of things that we can consider in order to try to help them. Some more issues on the medical side. Kids with a traumatic brain injury are more likely to have issues downstream, more learning disabilities, ADD, speech and language problems, developmental delays, anxiety, bone, joint, or muscle problems. I want to point out two of these. A lot of times kids will make it back to their primary care provider with complaints from the family and from the school about ADD, attentional difficulties, and they will get treated for that at their primary care provider. That's not a bad thing, but what happens is it misses potentially a bigger picture, because they might also have a problem-solving issue. They might have impulsivity issues. They might have a difficulty now with reading that they didn't have before. So we really need to dig deeper than that. And that's this is a great red flag. If a child who has had a concussion comes to you with a report of ADD, we want to look deeper at that concussion. Or if anybody comes to you with a complaint of ADD, you might want to dig and just look at whether they've had a concussion in their past. The other one that is significant to me is the bone, joint, or muscle problems. This is because if we think about how people are injured, like a car accident, like a fall down the stairs, anything that is really jarring to the body like that may have produced some spinal misalignment. And what can happen with that is as the body is trying to deal with that and pull things back into place, they might show up in their nurse's office or in your office with a shoulder pain, and now it's a neck pain, and then it's a hip pain, and it looks like maybe they're trying to get out of things, out of work. And the same can happen with adults. They can have these same problems. It doesn't fit into any sort of pattern. But it can be from the spinal misalignment injury, so that needs to be checked out. They do need ongoing monitoring and referral. Children with all levels of injury, mild, moderate, and severe, are at more risk for persistent behavioral problems, and the risk rises with severity and the younger age at injury. Now, I'm talking a lot about children, but hang in there. We are talking about adults throughout this as well. This is for everybody. And a lot of times, I'm showing you the studies, but a lot of time the issue is the same for the adult population. So even in children with skull or brain tissue damage on imaging, so they've got something showing up. A lot of concussions, we don't see something. These folks had something. Only 1/4 received any rehabilitation service, and only 1/4 received a neuropsychological assessment. And the study concluded that healthcare providers should provide information to parents on what to watch for and long-term implications, and healthcare providers should make appropriate referrals at the time of diagnosis. Now, I'm going to talk about our concussion management protocol. That talks about at least by the 4-week point making those referrals. So they may be, this is probably more if you have a significant injury, like they're saying within hospital systems, that they should just automatically be referred to rehab. Rehab can come into the unit that they're on and just start right there, because they're going to have a different perspective on things. And then referral to rehabilitation can help with transition to preschool, but it can help all along. It can help going back to any level of school. It can also help with transition back into the work environment. We don't have a lot of, this is another, I'm showing you problems that the literature is showing us. So we need ongoing monitoring. So even if they are cleared at some point, and they can be cleared at many points along the way, they still may need supports, and they need monitoring. So if the issue with the early intervention systems, and this is nationwide, is that because of the nature of TBI, the young child, so early intervention is under 3 years old, they can pass that initial developmental screener. They haven't had time to kind of fall off from developmental issues. Obviously, if it's a significant traumatic brain injury, things will be present initially. But with more of concussion level, mild injuries, then it might take time for those issues to really show up. So we might need another referral to early intervention, or a referral, if they've aged out of that, to another system. If they've been admitted to a hospital, the example that I used earlier on the right-hand side of those two, admitted to hospitals for 3 and 4 nights and treated and released. They still may need supports, even though they've it looks like they've been cleared by someone else. We need to watch them. They might have just been that first block on all of that data. They were treated at the ED and released. We still need to watch them. Medical issues at the time of injury, like an unstable intracranial pressure, blood pressure, or oxygenation issues, delayed nutrition, or seizures, they're more likely to have a decreased IQ at 12 months. So we need to be monitoring them over time. And even in mild traumatic brain injury, studies show there is a 17 to 33% incidence of cognitive deficits 1 year later. And all ages are more likely to have another injury, to become obese, to be incarcerated, to have substance abuse issues, including opioids, to become depressed and have other psychological issues, and to be socially isolated. And the list goes on. They're much more at risk down the line. And a substantial portion are not going to go back to their primary care provider during that first year following injury, but many of them will have unmet or unrecognized needs. And one of the reasons for the unmet needs is the physician's lack of a recommendation or a referral. And it may be that had they come back, that's when you would have referred. That's why we need to consider earlier referrals, or what the concussion protocol is going to recommend is bring them back. Have them come back. We'll talk more about that. And then obviously the cost. Some issues also on the medical side is family support is crucial. Where there was family dysfunction, poor coping, the child had greater dysfunction. So can we intervene there at all? Families reported needing information, emotional support, and access to community-based services. Even just knowing what those community-based services are. And then if, as a part of their medical care, we can provide systematic transition services, they're more likely to receive the supports that the student needs at school. So if we can, the school doesn't have to follow the medical recommendation, a primary care provider's recommendation, unless they're medical. If they're a medical recommendation, they need to follow it. But if it's an academic one, which the accommodations following a concussion generally are, then they don't have to follow them. But we do know that if you provide them, they are more likely to follow them. Use of the ACE tools, the screening tool and the care plan, which are both a part of the toolkits, they increased patient follow-up and they improved recall of and adherence to, this is in the emergency department, the discharge recommendations. Makes sense that office visits would be the same. If we're giving them something, then they're more likely to be able to remember, because they can just go back and take a look at it. So there was this very large study on 11 level 1 trauma centers across the country, and they found that less than half of the people seen received traumatic brain injury educational material at discharge, or saw a healthcare practitioner within 3 months after injury. Only 27% were called by 2 weeks, And then follow-up care varied widely by site, from 19% at some to 72% at others. So we have a lot of improvement, room for improvement there too. And for those with a positive CT scan, over 1/3 had not been seen in a medical practitioner for follow-up. So keep in mind that most concussions, they won't have a positive CT scan, but the ones that do, over 1/3 hadn't seen a practitioner for follow-ups. They had a more significant injury, potentially some damage that we can see. They also saw that even among those with 3 or more moderate to severe post-concussive symptoms, that's a pretty significant burden, only about half saw a medical practitioner within 3 months. And of those that did, 80% reported that it was helpful. And the majority saw a general practitioner, 38% saw a neurologist, and only 15% reported visiting a clinic specializing in TBI care. They are a great referral location, a site for you, because they are experienced. Now it depends obviously on what it is. A headache, a neurologist is probably a great referral. I'll leave that up to you. But for a lot of the cognitive, some of the physical issues, the ocular, motor, then a site specializing in TBI care is a great referral. And they concluded that not following up can have negative consequences. And since we know that just providing educational materials to those with mTBI improves outcomes, and so we've included educational materials in the toolkit. What the toolkit's attempting to do is fill all of these holes for you. And the study, they believe that the findings show that there's a lack of understanding among practitioners of the substantial symptoms and the life burdens experienced by many of those with mild traumatic brain injury. So keep in mind that these were emergency department visits. So someone coming in with a concussion is not going to look like as big a deal to them as some of the huge trauma cases that they're seeing. But there can be a substantial life burden on these folks downstream. So even if they can be referring back to the primary care provider, go see your PCP tomorrow or within the first week. We might be able to start to catch more of those. So I mentioned neuropsychological testing earlier. This is great no matter what the age of the person. It's not always needed, but they are going to, I put the school psychologist up so you can see in a school system that sometimes we think we've got it covered by referring them back to the school, but the school isn't always looking for the same thing. School psychologists do a great job at what they do. The neuropsychologist is trained to dig a little bit deeper. They go a lot deeper, actually, into the specific domains of cognitive function. So they're going to tell you about their verbal attention, their visual attention, their memory with delay and distraction. They're going to go really dig into all of that. And they're going to come back with some great recommendations for that person's life. And they're going to come back with some strategies or accommodations that that person can use. So if the recommendation for this happens by the primary care provider, then it's much more likely to happen. Again, it's not always needed. It's really great when there's either cognitive issues that you know of and you want to further delineate them, or the person is really struggling and you can't quite figure out why. Maybe they can't articulate it well. So you need to, a great referral is for neuropsychological testing, again, regardless of age. So let's take a look at the toolkit. This is for children through adults, and there are 4 categories of documents here. There's a big reference section, which is really there for you to kind of just take a look at, refer back to if you need to, but it's not going to be something that on a day-to-day basis you're going to need to be looking at. That would be the in-office use, and then the send home with family recommended. And there are many fewer documents there. We've really pared it down to what we feel was the best. We looked at everything and pulled out the best for you. And then because there's so much and a lot of it is good, we pulled out some additional ones that are there for you to take a look at and you may have a use for them. So there are 14 documents in the reference section. The concussion protocol is arguably the most important thing within the toolkit. And this, like I said earlier, is based on the gaps that we see in the literature. We're attempting to bridge those gaps. I recognize that you probably can't read this or see it real well. It's in the toolkit, so just take a look at it there. We are asking providers to think of concussion as a 2-visit minimum diagnosis. So on that first visit, you diagnose a concussion. That means you're bringing them back at least once. That first visit, you're using an assessment tool. We recommend the ACE put out by the CDC, the Acute Concussion Evaluation. We have the physician clinician office version in there. There is an ED version as well, which is easy to get at the CDC site. And then we ask that you provide symptom evaluation tools for, if it's a child, an age-appropriate one. Remember that there isn't one for 5 and under, but there is for 5 and up. And then there's an adult version if it's an adult patient, and then there's also a parent version. So then we are asking, so you're using that to help with your diagnosis, and then we're asking that you give an extra to take home with that adult patient or with the caregiver, so that now over the next 4 weeks they have something to look at to help guide their decision about whether there's a reason to come back or not. Because what happens is the further you get away from the concussion, the more it begins to look behavioral, academic, social, psychological, and it looks less medical. So they don't think to come back to you, even though you would be a great source of help for them. So we're asking that you say to them, please come back in 4 weeks. If you want to say come back in 4 weeks if symptoms persist, you can. Obviously, some people won't come back if there's nothing going on. That's great. We're not trying to catch them. But then if symptoms persist at that 4-week mark, we want you to be making a referral at that point. Let me just jump back for a minute. Also at that first visit, we want you we are requesting that you give some educational material to send home, because remember that just providing educational material improves outcomes. And you may not get a second chance to provide that. We've heard people say, well, we don't want to upset them about what might happen. It seems to be the opposite will happen, that if you don't provide it initially, they don't know what's going on and they will really struggle. So we're asking that you provide it up front, and we're giving you the tools to do that. So jumping back to that 4-week post-injury, we know that most symptoms are going to clear by that point for most people. So if they do have symptoms persisting at that point, we're asking that you make a referral to the appropriate person if it's something that you can't handle in office, because there's now brand new research. We'll talk a little bit about some of that coming up, where if we we can now treat concussion. There are very specific things that we can do for each symptomatology kind of grouping, and we need to think about who to refer to. So it might be, there's some suggestions here, there's some more on another document I'll show you, a specialized concussion treatment center. I think that's always a great choice. I am biased. I worked in one for many, many years, and we saw all kinds of concussions come through that door. A neurologist, a symptom-specific specialist like a neuro-ophthalmologist, a brain trauma rehabilitation program. That's actually where I worked. There are now some specialized concussion, especially sports concussion, opening up around the country. A neuropsychological evaluation, early intervention if they're under 3, school district if they're 3 to 5, or the school if they're 5 and over. Consider also, though, with children, we don't need to just refer to the school system. We can also refer to a specialized brain trauma unit, because sometimes they are going to be better equipped to deal with the aftermath of concussion and traumatic brain injury. And then we ask that at the year mark, or any yearly checkup, anytime you see that person again, kind of flag that concussion in some way in their chart, and then you just ask about it, so that we want to point out to them post-concussion, what changes have happened in their life. Is there anything different? Because again, the further out you go, the less likely you are to put it back to the concussion. And there are treatments that we can use even a year later or more. There's a link to there are new pediatric guidelines that came out in September of 2018. And they have 5 key recommendations, but I recommend that you read all of it. There are also some at-a-glance I call them cheat sheets that go along with it. And the 5 recommendations are: now that we are not routinely imaging patients to diagnose mTBI, use that validated age-appropriate symptom scale. Assess evidence-based risk factors for prolonged recovery. We now know what some of those are. Provide patients with instructions on return to activity, customized to their symptoms, getting them back into activity. And then the last one is about non-sports, counsel them to return gradually to non-sports after no more than 2 to 3 days of rest. The conventional wisdom used to be they rest until their symptoms are gone. What new research shows is that will actually prolong recovery. If we don't get them back into their daily life, and this doesn't mean that they're doing everything that they used to do, but we need to get them back and going. And if they need to rest a little bit more, then that's fine, but they need to get back into life, and that's actually going to speed recovery. There are, in the reference section, there are 4 of the 5 supplemental documents to those pediatric guidelines. Like I mentioned, there are 3 at-a-glance versions of the guidelines. There's one focusing specifically on diagnosis, one on prognosis, one on treatment and management. And then there's this great checklist, kind of a flow sheet in a sense for the healthcare provider. There are also contained in the reference section the updated mild traumatic brain injury guidelines for adults. They are there. The Tennessee Return to Learn, Return to Play guidelines. It has information about Tennessee's sports concussion law. It has talks about how to return the child to the classroom. And very importantly, it also shows the gradual return to play plan. And I will talk more about this in a moment. On when you are returning them to sport, you want to consider things like the athlete reports, right? Because that's all we can really know. They report no remaining symptoms. The athlete has been warned of the dangers of returning to sport while symptoms persist. So you've done your due diligence there. So just very briefly, if someone, and it seems to be under 23 years old, if they return to sport or anywhere and sustain a second concussion while they are still recovering from the first concussion, it's like the brain can't handle that. There's a catastrophic swelling response, and it's very hard we don't really have good tools to pull back from that. And there have been some catastrophic outcomes, including death. Doesn't happen often, but it happens. So we just need to be warning them so that maybe then they will report those symptoms to you if they have them, if they are having them. And then consider that you can also clear to participate in Tennessee's gradual return to play plan. And that was designed to better assess them under physical exertion. So it's day 1 through day 6, and it is a stepwise progression. So you can be clearing them to return to school or to their sport to participate in that. And then you can either say that, after that they are cleared, or you can have them give you a phone call, and you can give or they can return to you and give obviously the ball's in your court with that. But these are some really good things to know about. Report no symptoms, they've been warned of the dangers, and I'm returning them to participate in this gradual return to play plan, because typically you're not going to see them under exertion in the office. You're not going to go through all of those steps. Also in the reference section is our Brainlinks flyer. This is good to give to the school system and ask them to invite us in to help train them about that student or about concussion or traumatic brain injury in general. And then It can go to work. It can go to providers that you have in the community that you like to refer to, especially if maybe you're in a rural area and you have providers that aren't used to seeing this. They usually just need a little bit of information, kind of a paradigm shift to what traumatic brain injury is, and then we can help them with that, get the information that they need. Also in the reference section, there is a great accommodations and modifications sheet that comes out of CBERT, the Center for Brain Injury Research and Training out of the University of Oregon. And we love it because it gives sample accommodations, modifications, so that you can kind of use it as a tickler. You can either check off the things on that and then turn it into school, or you can look at that and then put them into your letter or your care plan. But it makes you think of things that maybe you don't typically use but might be appropriate for this client. And then for the employee, there's information on the Job Accommodations Network. There's a flyer there. They provide work accommodations and help for getting back to work. And there is also so the flyer is within the reference section. On the table of contents page, there is a link to brain injury specific accommodations, the Job Accommodation Network. So the first one is general, and then the link is specific brain injury accommodations. And then this I really want to bring your attention to, because this is a lot of that new information. There's a lot of research around 6 clinical trajectories of concussion. If you want to read more, there obviously are the specific studies, but it's also contained in this book, which is Concussion, a Clinical Profile Approach to Assessment and Treatment by Anthony Contos and Michael Collins. And it summarizes these 6 clinical trajectories. The top is color-coded to the flip side, which is a great infographic from the University of Pittsburgh Medical Center, where both doctors are out of, that lists the different types of concussion and a little bit about them. So that coloring at the top refers to the opposite side. And this is a document that we developed based on all this research, and that gives you some of the facts that symptoms are going to be broad and generalized within that first week. So when they first come into you, you may not see any of these trajectories appearing. It's going to be after a week. And then after that first week, they might fall into more than one trajectory, 1, 2, 3, something like that. And so that complicates things a little bit, but it does help to think, okay, it's looking like this, it's looking like this is there too. And then the specific trajectory and outcome depends on several factors, including the direction of the force. Is it linear? Is it rotational? The location of impact, the amount of force involved, and the pre-injury risk factors. As an example, if you have pre-injury migraines, you're more likely to have them post. And then the research says that active, specialized treatment focused on the specific symptoms helps the brain to recover from injury. And there are also some more referral options listed: neuropsychology, vestibular physical therapy, exertional physical therapy, physical medicine and rehab, PM&R, neurooptometry and neuroophthalmology and orthopedist, neurosurgery, neuroradiology, chiropractic, cognitive therapy, speech language therapy. So yeah, there are lots of options. If one is not available in your community, another may be, and if nothing is, bring us in and we'll help the appropriate person to learn what they need to. And then there are some risk factors that are listed on the bottom: history of prior concussions, motion sickness, visual problems, learning or attentional issues, migraine history, female gender, and the age. The younger children tend to take longer to recover. But again, the research supports targeted, active treatments. We're no longer letting them just recover on their own. The final 2 tools are: there is a CDC put out an online training for healthcare providers where you can earn free 2 CMEs or whatever kind of credit that you need, but it's free. It's a great training. And then there is a research summary and some references that we put together that is support for this toolkit. It takes the relevant literature, summarizes it down in a quick and easy to read fashion, so you can kind of at a glance see what's more than at a glance, but you can see we've synthesized it for you. So now, in-office use. The color at the top, the border, corresponds to the section in the book. So the in-office use, the acute concussion evaluation that we talked about is there. It looks like a ton of information. It takes 3 minutes to complete. And it has all of the things that you need to know specifically to diagnose concussion. There are some things that you won't really need to use, like the bottom part is red flags, and so not that you need to do that within the session. And then in-office use, the other thing that's there is the post-concussion symptom inventories that I talked about when I was talking about the concussion management protocol. And remember that we're asking that you send one home, whether it's with the adult patient or the parent or caregiver, to have something to look at over those next 4 weeks, as well as the patient education, which we will get into in this section. So now this is the send home recommended section. Something that's there is a symptom tracker. You can use this for other things, not just brain injury related symptoms, but it's a way that the family can gather, or the patient can gather information so that you can make some better decisions the next time they see you. So now it's data-based. And we're also giving this out to school nurses so they can be gathering that information and then looking for patterns themselves that teachers might be able to use to make some accommodation recommendations that they can start to use. Or in the case of like headache, where you're considering medication or things, this can come back to you. It's simple, it's quick. You take a look at the symptom, what the intensity rating of the pain was, 0 to 10, what was happening when it occurred, what happened, what'd you do about it, and then what happened, what was the outcome, and what was the intensity level at that point. So hopefully we can learn some triggers. Also in the Send Home Recommended, there's the ACE care plans put out by the CDC. There's a school version and a work version, and it's that helpful document that we said if you use this, they're much more likely to follow up on your recommendations. And then there is, with the pediatric guidelines, the CDC put together a return to school letter, and in the doctor's offices that we have been going into so far, they've loved receiving this. It has the symptoms on the front, on the back. There's a place where you can check off some accommodations, so it's a real easy to use. And this is the 5th supplemental document. Remember I said there were 5. This one just kind of belongs in this section, supplemental document to the pediatric guidelines. These are 2 documents that we are really excited about. There will be a 3rd for adults. This is when concussion symptoms aren't going away. And the first one, the blue one, is for 5 and under, and the second one is for school aged, and there will be an adult one. That adult one will focus on signs and symptoms, danger signs, but it will also have returning to college information and returning to work information. The 5 and under, the blue one, in addition to those signs, symptoms, danger signs, when to return back to your doctor, it also has what do you do down the line. So it will talk about referring them to TEIS, to making sure that they have documentation from you that documents the brain injury. Sometimes it's better if it says mTBI versus concussion, even though the pediatric guidelines are recommending that we call a concussion an mTBI instead, so that people understand this was a traumatic brain injury. I think it's going to take a long time to get that wording to kind of stick into kind of the national vernacular. So it gives them information about what to do, that having that documentation from you, what to do at each step depending on what age their child is. And then the greenish one talks about issues at the school level. So also needing things in writing, needing documentation from you, It talks about the 504 plans and IEPs, how to go about them, because if you have a typically developing child and typically learning child before that time, you don't know anything about the special education system. So we are asking that this be the document of choice. You pick the one that you need and that you hand that out on that very first diagnosis visit. There are other tools that you can send home as well. There is a concussion fact sheet for parents. This one we like, and we put it in here because it focuses on athletes, so it's really good for sports physicals. It will talk about what are you looking for on the field. They look dazed and confused. They don't know what play they're on. They don't know who they're competing against, things like that. So that's great for handing out sports physicals. And then there's a CDC flyer for families. There are signs and symptoms handouts that are English and Spanish. So again, we'd like you to default to the two documents I just talked about when concussion symptoms aren't not going away, but are also 3 others. In the meantime, you can use the adult version until we come out with the adult version of the other one. This adult version includes information on concussion in the elderly, so it will also work for that population. You can kind of point out that section on the back. And then the young child one can also be used with someone who is nonverbal. We've been working lately with a lot of populations like intellectually and developmentally disabled population where they have a significant portion of people who are not able to communicate with words. So for now, that young child one would apply, but we're coming out with something better. So stay tuned. There is also our Brainlinks regional contact information, and then the Tennessee TBI Service Coordination Brochure. This is really important for you to know about. We're finding that people do not know about this, that there are in the state of Tennessee 8 service coordinators, an amazing resource, especially if you have someone who is more significantly impaired and therefore the case is more complicated, or if you have a parent who is, for whatever reason, having difficulty navigating all that they need to, whether it's insurance or where to go, what to do, other funding options. The service coordinator can help with that. And so that's a great referral source for you to have in your back pocket there. And then this is information on us. We are a small but mighty team, I love to say, and we cover the state of Tennessee, providing resources and education. And I thank you so much for your attention and for listening to all of this and incorporating it into your practice. Thank you for all that you do.